speaker. This is Dr. Teresa Kaldis. Dr. Teresa Kaldis did her med school at UT Houston, and then she did her residency in PM&R at Baylor College of Medicine. She's currently the PM&R section chief and also director of consult service at Houston Methodist Hospital. She's also assistant professor at Will Cornell Medical College, and her topic today is exercise as medicine. Dr. Kaldis.
All right, well, thank you. I'm glad to be included with this really exciting conference on stroke. I think you really see from the conference how many people, how many different folks touch stroke and how we all look at this very differently. My talk is a little bit generic. Exercise is medicine. I'm going to focus, because as you know that topic is very big, going to focus on more chronic exercise is medicine in stroke. So we all know the benefits of exercise. I think for me, I'm not going to talk much about whether exercise works or not, or how it works. There's a lot of different studies, and I think that's more for another talk. I'd like to get through a little bit about how it helps on the physiologic effects, and then talk a little bit about practically how, if we agree exercise is beneficial, how we agree to move forward with an individual patient, and really some practical nuts and bolts. My neurologists have wowed you with, a lot of, do I need to move? Okay, wowed you with a lot of studies, so you can take a break from memorizing the ICE trial, MIGHTY trial, BEND trial. I just have no trials to show you. We're going to talk about the nuts and bolts of really looking after a patient and how we help them recover from a stroke, especially when they're further out and away from a lot of the medical care. One of the things I want to point out is you can lose the effects of exercise within about 2 weeks if activity is substantially reduced. So just imagine all that hard work you've done, 2 weeks of bed rest, which some of our stroke patients get, and you're already starting from a negative. So exercise types, aerobic, anaerobic, strength, balance, endurance, flexibility, moderate intensity, vigorous intensity. What I would tell you for our stroke population is all of these forms of exercise can be helpful and good for an individual patient. It really depends on what you're trying to accomplish. The 3 times a week, 20 minutes, really a lot of that came out of the cardiovascular health. And as you can see, your goals may not necessarily be cardiovascular, although that is a good one. So there have been many studies showing exercise health benefits for all kinds of diagnosis. I would like to say, exercise treats everything. There really isn't anything that it doesn't treat, and it has very few contraindications. So diabetes, obesity, heart disease, hypertension, hypercholesterolemia, infection, cancer, osteoporosis. I would say maybe the underlying theme is really reducing inflammation, and that's gotten a lot of attention in recent about the metabolic syndrome, but low-grade inflammation is probably an underlying factor across all of these different diagnoses. And if exercise just reduces inflammation overall, we may get many, many more benefits. And of course, we could have a whole different discussion about prevention versus treatment. For instance, someone who is trying not to get diabetes, you could do an exercise program for prevention, and someone who already has diabetes, you could do exercise for treatment or to reduce as treatment for the disease itself. How about cognitive effects? Interestingly, I think early on in my career, we looked at get cognitive benefits, you had to do cognitive exercises. So you had to do crossword puzzles, you had to engage your brain, you had to do puzzles, you had to do Sudoku. But really, exercise, even the cardiovascular, even aerobic exercises have been shown to have cognitive benefits. So exercise has been shown in many studies to have benefits in dementia, depression, anxiety, ADHD, addiction, insomnia. We heard earlier today that mental health and stroke. So you kind of, for me, you get a mind-body experience with the exercise piece. Plus you get socialization. There's a lot of different components that exercise gives us that I would say is really hard to lend itself to studying in isolation whether a particular exercise is helpful, because it just has so many different aspects that it affects, whether you like to exercise, don't like to exercise, what activities you like to do. So just a couple, one of the things I just pulled was exercise and stroke, so physical effects. There had been a recent study said the effects of high intensity interval training after stroke, and essentially it concluded that high intensity combined with standard care improved walking distance, balance, and executive function immediately after the intervention, but at 12 months, no sustained effect, okay? You heard earlier from my colleague Mitch, who spoke about exercise. One of the things I thought he really pointed out, unlike our I think other specialties that deal a lot with medications, there's a lot about dosing and how much and how often and when, and we really have very little individual data about exercise dose. Is once a week enough? Is twice a week? Is 7 times a day? I mean, it depends probably on what we're trying to accomplish, but we really, what dose of exercise to give in the acute phase of stroke and in the more chronic phase, we really don't have much guidance. Exercise therapy in balance capacity in stroke, there's been a number of studies that have shown that balance capacity is improved with specific balance exercises, but again, if you don't continue to do them, you essentially can lose the effect. And you know, some of that makes sense if we think about ourselves exercising. I know if I have an exercise routine for the next 30 days and then I don't do it for the next 9 months, most likely I'm not going to retain any of the benefits from actively exercising. Exercise and cognitive. Interestingly, going back to the combining, when we talked about music, effects of combined interventions of physical exercise and cognitive training. So there were some folks saying, hey, we know activity is good, we know engaging the brain is good, maybe if you combine them, they're better. And again, both can show that they were a little bit better than either alone. The difficulty is showing sustained effect. I can tell you there's a lot of different diagnoses. If you look at, can we extrapolate data from different diagnoses? Almost all of the exercise studies will show you in the short run, we can improve strength, we can improve flexibility, we can improve VO2 max, we can improve other physiologic parameters, but sustaining it without the treatment, it just doesn't have a lasting effect. So the American Heart Association, American Stroke Association, they have a very nice website where they've tried to have a place for stroke patients to go to look for data that may be up to date. And essentially on their position paper, their conclusion was the promotion of physical activity and stroke survivors should emphasize low to moderate intensity aerobic activity, muscle strengthening activity, reduction in sedentary behavior, and risk management for secondary prevention of stroke. And I would argue that was true for all of us in the audience. That would be good advice to take. So how do you actually prescribe an exercise program? One of the things, my mom is a retired rehab physician, and she always said, Teresa, one of the things we've struggled with in rehab is where does the therapy gym start? And where does the exercise gym in the community start? Like where is the continuity across that, or where is one start? I would tell you, for me, I would say with a stroke patient, because you're already talking about someone who probably has other health issues, starting with a physician and doing a supervised program would probably be better than them just going out on their own. But if you go low and slow and listen to your body, many stroke patients could start a program on their own. So I look at evaluating their baseline function, evaluating what limitations they have to movement, explore what the goals are together. Why do they want to get better? What exercise do they want to do? Explore their support system. And again, this is true for all of us. If you're going to be successful at changing behavior, having a good support system, having a coach, having a family member, having a partner, all increases our chances of success. Consider start with PT, OT, or speech, depending on what goal you're working on, to help get started. I really think that helps set the habit. It's really hard to get something started, but once you've got it started, easier to continue. And then I really emphasize to the patient that the therapy program is not the end. It is just the beginning of changing their behavior, changing habit, helping them exercise safely, looking at, for instance, if they want to lift weights, how do they do it safely and not injure themselves? And then really focusing on transition to a home exercise program. All of the therapy is covered by commercial payers and Medicare, and that's limited. It is for a medical intervention. You have to show goals. You know, many of our patients with stroke would benefit from working with the therapist throughout the year, but the therapist currently in our reimbursement system can't continue to work with a patient for maintenance. So if it's only maintenance goals, so I really work with any of my patients to say, okay, the therapy is limited. While you're doing it, you need to be thinking, can you do this at home? Do you need to join the gym? Do you need to find a friend that you can work with? Do you need a support group? How are we going to maintain? Because once they're left to their, once they're out of the therapy, then maintaining it is really a challenge. And I will do follow-ups like every 3 months, because I think if they have someone to check in with, then we're more likely to be successful for the year. And then if things are really complicated, or the patient has a lot of limitations, or they have some joint restrictions, or they have spasticity, then consider a referral to a rehab specialist where you have that little bit of extra expertise for special cases or more challenging. So exercise is medicine. Let's look at like baseline function. So you really want to know, if you're evaluating an individual stroke patient, how are they walking now? Do they use a cane? Do they use a walker? Are they walking independently but they have a brace? Do they need an AFO or a brace plus a device? Are they wheelchair level? There's a great program called Sit and Be Fit for folks who have already modified a program for patients who are sitting. This is good for your geriatric population, even if they don't use a wheelchair, but if they're more sedentary. Are they already dependent? And a broad question with their ADLs, can they do everything by themselves, or what activities do they need help with? Evaluate limitations. So is it a strength issue? Is it a sensory issue? Is it a proprioceptive issue? One of the things I think for me that gets missed a lot is folks have good strength and fairly good sensation, and everyone thinks that they're fine, but they have no proprioception. And it's really, if you can isolate that that's their problem, there are some really specific things to focus on to really help those folks. If they just did strengthening alone and they may not see their benefit, spasticity is certainly helped with exercise and stretching and flexibility. But if it's markedly restricting their movement, you may need to address that first. The range of motion, if it's already, they've lost the range, you also don't want to have someone, for instance, who has a little bit of a plantar flexion contracture, they've lost range at their ankle. You don't want to have them increase a lot of activity on it and injure it. You may need to address that first. Balance, and then the other thing is their visual effects. So a number of our stroke patients, if they have a field cut, our left hemi for me is left side of the body, right brain, but if they have inattention, then often that you have to take that into account. Our OTs and our PTs both are trained to take into account kind of the visual deficits that the patient may have that's affecting their ability to safely move. So I just start with a patient like why. I just pull up a chair and ask them, how are you doing? What do you want to do? What do you want to make better? Do you want to get stronger? Is your balance? I have a lot of folks after stroke that get really fearful of movement because they don't want to fall. And if fall is an issue, again, you got to kind of tease it out, but balance is one of the big issues that contributes to fall in our stroke patients. The other thing is a task-specific activity. I have folks, for instance, who want to garden. They really miss being in their garden. So what activities can you tailor to help them get good at that activity? Are they looking at cardiovascular health? Do they want to lose weight? Are they looking at it from a mental health standpoint? There are some folks we know that really their depression is well managed if they stay active with an exercise program. And self-confidence. I mean, depending on what their goal is, may really make your recommendations different about what you recommend. explore their support systems. We touched on this a little bit earlier, but do they live alone or do they live with family? Do they drive? One of our stroke patient problems is transportation. So do they live in in an urban area where they have a lot of options? Is there public transportation? Is there Metro Lift? Do they live rural and they're really isolated and dependent on someone, primarily family? It's hard to get an Uber, when you're not in the city. Right now, I have a number of folks whose families work and they take an Uber, those who are appropriate to their therapy program, which until recently wasn't really an option. Some of your folks may live in centers now, or they live in apartments or senior living that have fitness centers actually on site. So sometimes I'll order home health therapy so that the therapist can work with the patient at a gym, at a fitness center they have access to, and that way show them, once the therapist leaves them, what they should continue to do. And then there's all kinds of exercise on apps and smartphones. You really have to, across any field of medicine, I think you have to look at how techy a person is. If they really aren't very tech savvy, you could have all the gadgets in the world, it's not going to be very helpful. But if you've got someone who's really tech savvy, they love their phone, they love all their devices, there's a lot of great stuff out there that would really help those folks be successful with exercise as medicine. Where are you going to begin? Are you going to start at home? You start in the gym? You start with a doctor's appointment? I think you're really going to have to individualize that. I think kind of in heading and bringing this together, everyone benefits from moving. There are very, very few things that benefit from bed rest. Maybe an unstable fracture, maybe an active MI. I would say things that would, medical and surgical diagnoses that would put you in the ICU, maybe you consider moving, but everything else benefits from moving. I often, for my hospital, I have a hospital-based practice mostly, and sometimes I really struggle with having folks getting up, and especially helping my other colleagues understand that moving is important. Even being out of bed is exercise early on, not as much later on, but early on. So I will ask any of my colleagues, like, what's their indication for bed rest? Ask your bedside nurse, what is the indication for bed rest? And they'll be like, oh, they're not on bed rest. And I'm like, well, that's what we have them on at the moment. So really also looking at attitude. I encourage my patients to do what they like or they love. I often get asked, like, what is the best exercise? What should we do? And if I told you biking had been shown in every study to be the exercise that helps stroke, and you hate biking, it doesn't help that individual. So although there may be studies to show different benefits, I would just say you've got to go down, at least for me, on an individual patient and see what do they really like to do, love to do, what will they do. I like aquatics, and not everyone, some people don't swim. So, but if they swim, there's a ton of benefit. And if they like already being in the pool, there's stuff you can add there. I try to get them to commit. You got to start somewhere. So just get them commit to moving, commit to some sort of program. And even if they start small and increase slowly, it's still better than where we were, okay? Encourage them to build stretching and exercise into their daily routine. The other thing that we all struggle with is being too busy and not enough time. And when do I have time? There is a lot I can tell you can do if you build it into your routine. While you're brushing your teeth, for instance, in the morning, you can do a static squat. Okay, you can do lunges all the way to the kitchen to get your coffee. Okay, you can stretch at the elevator. You get a lot of looks if there are other people at the elevator, but you can do it. But I would tell you part of it is just bringing it into your consciousness and thinking it's important, and then how am I going to build this in? Encourage them to be individual. I just don't think this cookie cutter helps everyone. And again, you can show them a lot of studies. I think you just have to agree that exercise is good. There's all kinds of benefits, and how can this person get moving? There's a thing we talked about earlier, like plyometrics is another part of a type of exercise. And if you look at it, it's kind of like if someone wants to be really good at basketball, you don't have them go play golf. There's not much overlap in the skill set they need. So I try to be activity oriented. I think that's a lot more helpful than telling someone they need to lift weights. A lot of exercise can be boring. So whole activity, start thinking about that. If they want to play golf, get them doing that more. If they want to do gardening, get them that more. And consider that their exercise. We've all, I think, kind of been taught, like, if you don't go to the gym and work out for 30 minutes, somehow you're not exercising. But there's a lot of different ways to think about exercise. And we, in my opinion, need to all do it and do it well and incorporate it into our daily life. And although I didn't spend much time on there are some concerns about the negative effect of stroke, of exercise and stroke. You got to watch for blood pressure, right? There's, you have sensory, so you don't want to injure someone. There are falls, so I don't want to minimize that, but I'd like to leave you that there's just far more to be gained with exercise than the harm, and a lot of the harm can be mitigated when you look at an individual. And I thank you, and I will take any questions that you may have.
Dr. Kaldis. I guess I will be doing lunches in my one question I wanted to ask you was, as you mentioned before, that sometimes the deficits that we see may not be the deficits that you see. Mm-hmm. And so sometimes what I've seen with the posterior circulation stroke patients where they have a cerebellar stroke, they may have like good strength, but they're very off balance. Have you noticed any difference in recovery for patients who have like the MCA stroke versus cerebellar stroke?
Yes. So I will tell you, like any of the stroke, I tell my folks natural recovery is better than any exercise we have, right? From a pure neurologic and treatment standpoint. One of the symptoms that is most difficult to address from simply an exercise is balance. So most of my folks will tell me that their exercises don't cure their balance problem. There's a lot of folks who get benefit from strength and they get enough strength to do what they want. Their sensation after they get used to it doesn't really bother them, but the balance is it. So most of your folks will tell you if they're faithful, if they practice their balance exercises, their balance can be pretty good, but definitely if they don't do anything, their balance is terrible. So cerebellar and anything that affects balance is harder to address, but all of the strokes can benefit from a long-term program to address their individual deficits.
I think I have one more question for you. So when patients come to clinic to see me, they always ask me, especially the ones who have mild disability, they want to really get on the exercise train and do a lot.
Right.
They always ask me about like cross training versus high intensity training versus weight training versus, doing other things. So has like one type of activity shown to be more beneficial than the other ones, or it's just a...
Well, I'll tell you, the low to moderate, if you saw the stroke, the American Heart Association, Stroke Association guidelines, low to moderate, a lot of that I would tell you I think is on older data, that's kind of where that had come from. They're just, in fact, I was going through some of my journals this week and cleaning out, and there was a brand new study on high intensity interval training in stroke, brand new in our journal. So as you know, if it's in the journal, it hadn't even kind of gotten into practice. But at the end of the day, I think for me, we may figure out what works a little better, high intensity, low intensity. But if a given individual won't do it, it really doesn't matter. So at the end of the day, from a practical, designing programs, say for our therapy gym, having tailored programs, I think that's where it will answer those questions. But until then, just for a given individual, get them moving in whatever they will do.
Sounds good. Thank you so much.
All right.